Hi, Neil. So glad to see you again, and it's a big honor for me and a great pleasure to see you. How are you?
I'm very good, Alexander. It's really good to see you again too.
Thanks. Neil, yeah, today I have several questions to you, and they are more related to the not, very high professional psychotherapeutic level, but more to, let's say, a level of common people to society level or the level of peer-to-peer. So we know that statistically 40% of trauma survivors develop post-traumatic stress disorder or related stress disorders, which means effectively that 60% don't. So likely due to such factors as social support, inner coping mechanisms, and some others. So how can we differentiate those who require comprehensive support and psychotherapy from those who will likely cope independently?
It's a really good question. And obviously, it does vary a lot as to what proportion of trauma-exposed people develop PTSD. I mean, for instance, studies that we've done in the UK military show that, despite high levels of combat experiences, probably even at the highest, about 1 in 5, so about 20% of combat troops. But you're absolutely right. If you look after perhaps, say, people who unfortunately have suffered a rape, then it may be as high as 50%. So it does vary a lot depending on the nature of the trauma. I think what's really important is to keep in our minds at all time is that people who go through traumatic events often experience a completely normal, non-pathological reaction to that. And so therefore, in the first few days and weeks, and even the first few months, we should expect to see people who report some trauma symptoms, from each of the PTSD clusters. So they may be slightly avoidant, they might be hyper aroused or jumpy, they might have intrusive thoughts or nightmares or the like. And what's important is identifying these difficulties, but then in the first few days, weeks, and even months, is being able to monitor them. And in most cases, they will get better by themselves. In the UK, we have our National Institute for Health and Care Excellence, our NICE guidelines. And what they say about the management of PTSD is that we should do active monitoring. So keep an active eye on people who've been trauma exposed, check in with them ordinarily after about a month or so. I'm not saying we do nothing in between. And then if at a month they're really still suffering or symptoms are getting worse and they're really functionally impaired, that's the time that we want to say, let's try and get you some early help. If at that 1 month point, they are making recovery, but it's a bit more gradual, I think it's probably worth, again, active monitoring for a bit longer, maybe up to a couple more months, up to 3 months. And seeing again, are they recovering over time? And people's recovery trajectory obviously is not always the same. It might be, for instance, if they've got other things going on in their life, they haven't really begun to process or make sense of the event until the other things are out of the way. And a classic example of that might be, say, a group of media professionals who were on a deployment covering a big news story. They might, for the 3 or 4 weeks that they might be on that story, they might sort of put out of their mind the fact that they were having these symptoms and they were just cracking on, and they might not begin to make sense of it until they came back. So we have to recognize that the majority of early symptoms are normal and non-pathological, but at the same time, we need to actively monitor people and find the ones who aren't recovering because they need extra help. So how can we do that? Well, in an organizational setting or in a setting where you're called in early on, if you're a buddy, a peer, a manager, a friend, a family member, maybe even a healthcare professional, I think the important thing is not to adopt a mindset of, I'm going to see lots of ill people. So if you're identifying distressed people in the early stages, what you want to do is to put in place strategies to try and help those people have the most likely chance to recover. And what does that look like? Well, the 2 things that we know make a big difference in the early stages, and one of them you've already mentioned, which is social support, is having people around you who you're able to talk to informally, as and when you want to, at your pace, but not avoiding talking to them. And the other thing is also not exposing yourself to intense pressure in those first few days, weeks and months. So, for instance, if you were in a job where you were about to be sent off to do, if you were a media professional about to cover a news story by yourself, maybe just after a traumatic event is not the time to do that. Maybe you'd be better off in a team where the team were able to support you and provide you opportunities to gently interact and socially interact with them. So, apologies, there's a...
No problem. No problem. What are there some structured monitoring tools which you may suggest, or it's just a general term, monitoring?
I'm really sorry. Can you hear that now? Loud noise in the background?
No noise.
Oh, you can't. Okay. Oh, that's fine. Sorry. Could you ask that question again?
Yeah. What I'm saying. Do you have any example of active monitoring? Do you have any, I mean, can you suggest any tools to use for active monitoring, or is just general term, whatever you like, you may use as the tool for active monitoring?
No, so one of the tools that's often used is the TRIM process, trauma risk management. So TRIM is a peer support system that was developed in the UK military, and it involves having people who have been through a couple of days training, being able to speak to a colleague who's gone through a traumatic event at least 3 days afterwards, but perhaps sometimes a bit after that. And they're trying to identify if those individuals have developed any of those strong initial distress reactions. TRIM is an evidence-based intervention, so it uses a 10-item checklist that has a range of indicators that people might not be doing well. Things such as the person thought they were out of control during the event, the person thought their life was threatened, they might be blaming others, feeling shamed, having acute stress symptoms, and so on. And what a TRIM practitioner can do is to use that checklist, which they've been trained to use, to identify people who are struggling at first. If people are struggling, then they would want to help them get extra support and also temporarily have a reduction in the pressure that they're experiencing. You generally provide informal support for that first month or so, and then a month later you would go back and do a similar interview, identifying whether those risk factors have recovered. So people are now sleeping, they're now thinking more logically about what happened, they're not so worried about what went on during the event. And if people are recovering, you can reassure them and send them on their merry way. I'd give them some information as well, just to help them know what to do if they do have any problems. But if people aren't recovering, then in most cases, you would want to refer that person on to a mental health professional, who in the first case should do an assessment, because it might be that the person's problems aren't related to the trauma, or it might be that they're some other difficulty. So that healthcare professional's job is to identify whether this person needs to go forward and get professional therapy or care, or whether maybe they should be monitored for just a little bit longer to see whether they will recover by themselves.
Yeah, I see. You mentioned that TRIM is being used in the military, but is it applicable for civilians, for instance?
Yes, so it started in the military. That started back in the late 1990s, but it's now used by a wide range of different organizations, and including healthcare, including emergency services, train companies, because unfortunately train drivers experience people taking their own life quite commonly. It can be used in construction, the media, security firms. There's quite a wide range of what I would call trauma-exposed organizations that make use of TRIM. And although it started in the UK, it's now used in a number of different countries, including a little bit by the Ukrainian military, I'm very pleased to say, but also in sort of Belgium and in the Netherlands, Australia. There's quite a range of countries that make use of TRIM. And the key part about the TRIM training is it trains up people who are non-experts to have a good understanding of what trauma is. And so they can then have these active monitoring conversations with colleagues and identify how they're doing and whether they need extra support.
Excellent. You mentioned that TRIM is more for peer-to-peer. I mean, the level of common people, which is absolutely fantastic. But what about mental health professionals? Can they use this tool as additional source alongside with other inventories which we normally use to diagnose, for instance, post-traumatic stress disorder or something else?
Yeah, so we know in the early aftermath of a trauma that actually there isn't, or there shouldn't be a role for mental health professionals to come in and use mental health interventions and assessment tools in that first month or so. Now, I and many of my mental health colleagues find the TRIM process is really useful for if you get asked to see someone who's recently been involved in trauma, because you then adopt an interested, curious, supportive approach, and you ask questions in a similar way to their peers would. So you're not trying to do a mental health assessment to ask them about their childhood and those sorts of things. You're very much focusing on using the 10-item risk assessment checklist from TRIM to help you see how someone's doing. And then if you find they weren't doing well, rather than recommending treatment, you might recommend workplace adjustments, or to the individual that they seek out extra support, or perhaps, reduce their pressure for a while. So I think mental health professionals can use the TRIM process should they get called on to assist in the aftermath of a trauma. And that also keeps them away from delivering some sort of critical incident stress debriefing or counseling approach, which we know is not a good idea.
Mm-hmm. Can TRIM be used in settings like schools, for instance, to differentiate after some tragic or traumatic events, potential traumatic events, to interview children, for instance, or in universities, where we have more adult audience. So is it possible to use TRIM there?
So the process that we use to develop TRIM and the evidence upon which TRIM is based is primarily revolves around adults. So I think I wouldn't use TRIM under the age of 16 for sure. Okay. I think for over 18, I think it's fine. And I think between 16 and 18, it very much depends on the setting. And the reason I say that is that the younger someone is, the more important the family dynamic is as well. And so actually the TRIM practitioner is asking the individual about how they're doing. And really for a younger person's recovery from trauma, that very much depends upon how they interact and how they're supported by usually their parents, but whoever the adults are who are looking after them. So not really under 16, but over that, it's got a role. And we also have to remember that in educational settings, teachers themselves are also exposed to trauma, and certainly TRIM is a perfectly good process to help them.
Excellent. But I understand that so TRIM is the semi-structured interview, so which has some certain rules, some clear settings and everything. But the question is, can TRIM be partly, the questionnaire from TRIMs, or the awareness about how trauma or how does it look like? So the parts of TRIM, can it be used in our daily life, for instance, to recognize that your loved ones were traumatized, or does it give some tips how to support loved ones if you have some?
Yeah, well, the 10-item checklist from TRIM is very much a checklist based upon detecting early symptoms of traumatic stress reactions. So when actually we have people who are friends to TRIM course, one of the things we often do is to encourage them to go and speak to their colleagues, friends and family who might have been having a tough day or a difficult experience, not to do a formal TRIM assessment, but to try and pick up on all the risk factors that will pop out of those sorts of conversations. So absolutely, it is a way that you can teach non-healthcare professionals how to identify if there might be difficulties within family members and friends. But I think the thing you have to think carefully though of isn't just doing the kind of TRIM interview; it's what you do with that information. So, in a family context, if you spot that your spouse might have some traumatic stress reactions, perhaps from chronic exposure to trauma, it's not then necessarily directly easy to say, well, what you need to do is to go and get this sort of help, because you've got that family dynamic in there as well. So I think it is useful, but you have to think carefully about what you do about the information you get from a TRIM assessment in a family or friend dynamic.
Cool. How difficult is it to become a TRIM practitioner?
So you don't need any specific skill set. We train up sailors and policemen and teachers and train drivers. You just have to be interested. The course is 2 days long. It involves the initial part is about learning about what trauma is and learning about the trim risk factors. But then it very quickly gets on to seeing how people do it. So we do a demonstration and then into practicing how to use the skills. And I think what's really important in the trim training is that you're willing to get involved in having a go, because you're in a group where you do the group learning, and you're going to have to show that, you know, you have a go at asking questions, and you won't always get it right, and that's okay at the beginning of training. That's normally what happens, but everyone's in that same boat. Everyone's trying out for the first time. So as long as you're motivated to go on the course and you're willing to, you know, listen to what's said and do as instructed, it's not complicated at all.
Cool. Is there a scientific evidence supporting trim? Where does it sit?
Yes, so we started this in the late 1990s, and now there's over 15 published academic papers. We've got a randomized controlled trial in there. We've got some outcome studies. And overall, this is not penicillin for trauma. You don't touch people on the forehead and cure them, but it's got a strong evidence base. It helps mobilize or get people social support. It helps keep people functioning at work. It helps them get to professional help, which we know that some people need to. And importantly, and this might sound strange, it doesn't do any harm. And I think that's important because we know that other older methods like psychological debriefing have the potential to cause harm. So overall, I think it's a very credible peer support system with a strong evidence base.
Perfect. Neil, thank you so much. I know how busy you are. So one of the last question. What is, to your point of view, what is most important when we are offering support to our colleagues or friends or loved ones? What do you think would be the core element of giving support for the other? If, for instance, if you are not trim trained yet, but you want to give support as a human being.
I think the key thing is to try and employ active listening skills and not to dive in too early with solutions. You know, so the old adage, which is you've got 2 ears and 1 mouth, so make sure you do a lot more listening than talking, is really important. I think it's vital that whatever you hear, you don't show instant strong reactions. So people can fear that telling loved ones about how affected they are will make the loved one upset. So if you are listening to somebody who's telling you this trauma story and how terrible it was, you know, by all means acknowledge what they're saying. You don't want to have no reaction, but don't say things like, "Oh, that sounds terrible," or "That's horrendous," because you might inadvertently put them off letting you hear the whole of their story. And if you've got solutions to what they're telling you, keep your mouth closed with those solutions until the end of the talk. And at the end of the talk, the first questions you should be, once you've said, you know, "Thank you for talking to me," the first question should be, "What do you think would help?" So listen to what they have to say before you start saying, "Right, here's my 10 things you need to do." You know, that's great, but do some good listening. Don't overreact to what they're saying. Ask them what they think will help, and then collaboratively, hopefully, come up with a plan to make things better.
Perfect. Thank you very much, and I really hope that we'll have some other chances to discuss some more topics about psychology and support in the future. Thanks, and
Nice speaking.